Welcome to our Friday webinars, just conducted by Yashoda Hospital in coordination with SEMI. Myself, Dr. Azim, emergency consultant, emergency medicine, Yashoda Hospital, Malakpet. Today, our topic of discussion is regarding thoracic trauma, and our speaker is Dr. Tarun. Sir, over to you, sir. Dr. Tarun, sir.
Yeah. Good evening, one and all. Today, we will be discussing on thoracic trauma.
Yes, sir. You can continue.
So, coming to the thoracic trauma is the significant cause of mortality in major injuries. So, it causes around 10 to 15% of mortality in accidents. And whenever the patient comes to the hospital after injuries, they'll have the high mortality rate. So, less than 10% of blunt injuries and only 15 to 30% of penetrating chest injuries require operative intervention like procedures. And most patients who sustain thoracic trauma can be treated by technical procedures with the capability of clinicians trained in the ATLS. And coming to the chest trauma can be divided into blunt and penetrating trauma. Coming to the blunt trauma, so blunt trauma can be again divided into acceleration or deceleration injuries and into high motor vehicles injuries and fall from the above 3 meters and sports injuries and compression injuries like anterior, posterior and transverse injuries and blast injuries can be seen in blunt trauma. And penetrating injuries will be again divided into high velocity and low velocity. In high velocity, it is divided into gunshot injuries and missile fragments injuries, and low velocities again stab injuries. And physiological consequences of thoracic trauma are hypoxia, hypercapnia, and metabolic acidosis. And there may be contusion, hematoma, and alveolar collapse or changes in intrathoracic pressure relationship. Examples of the major thoracic trauma includes tension pneumothorax and open pneumothorax can cause hypoxia and lead to metabolic acidosis, and that leads to sudden cardiac arrest. And hypercapnia causes respiratory acidosis and most often follows inadequate ventilation caused by changes in intrathoracic pressure relationship and depressed level of consciousness. Coming to the assessment of trauma patient in thoracic trauma, there is primary survey with resuscitation of vital functions like ABCD we have to rule out, and detailed secondary survey and definite care depending upon the injuries. Coming to the primary survey, in primary survey, ABCD, as we can follow ABCD, in primary survey, we have to treat the outmost important injuries because it may cause life-threatening injuries. And in airway obstruction, results from swallowing, bleeding, or aspiration interfering with gas exchange. Laryngeal injuries can cause into subcutaneous emphysema, and it cause hypoxia and sudden cardiac arrest in ED. And posterior dislocation of clavicular head occasionally leads to the airway obstruction. Penetrating trauma involving neck or chest results in bleeding and obstruction. Signs of airway obstruction in thoracic trauma are air hunger will be there, and hoarseness of the voice will be there, stridor, gurgling, snoring, intercostal and supraclavicular retractions will be there. And treatment in thoracic trauma in airway obstruction, first we have to keep airway agents like OOPA, NPA, oropharyngeal airway and nasopharyngeal airway, supraglottic devices, and definitive airway like intubations, and if required, if definitive airway is very difficult, we have to plan for the needle thoracotomy and tracheostomy also. And coming to the tracheobronchial tree injuries, it may be again divided into the blunt or penetrating trauma. Intra or extra thoracic locations will be there, like supraglottic, glottic, and subglottic injuries might be divided. And presentation of patients in tracheobronchial tree injuries will be massive, and sometimes uncontrollable air leak will be there, stridor, acute respiratory stress, voice change, neck and upper chest subcutaneous emphysema, often massive and disfiguring changes will be there. Management in tracheobronchial tree injuries will be acutely managed with bronchoscopy. Deep intubation beyond injury should be placed because to further damage, to occlude the damage of the tracheal bronchial injury. So bleeding is there and everything. And sometimes tracheostomy also might be required. Coming to the breathing. In breathing, tension pneumothorax will be seen. And in tension pneumothorax, it is defined as a one-way wall air leak occurs from the lung or to the chest wall, and air is forced into the thoracic cavity, eventually collapsing the affecting lung. So it is the air accumulation will be there in the basilar and parietal pleura. Due to of that, the lung will collapse, and it is and the deviation of the trachea will be seen to the opposite side. And here in this X-ray, we can see the left lung is totally collapsed. There is no haziness and haziness of the bronchiovascular markings and everything is gone. And left side, massive pneumothorax and tension pneumothorax is there. And trachea is deviated to the right side here in this X-ray. And clinical features of tension pneumothorax are chest pain will be there, and hair hunger, tachypnea, respiratory distress, tachycardia, hypotension will be there, tracheal deviation away from the side of the injury, and elevated hemothorax without respiratory movements, distended neck veins, and unilateral absence of breath sounds will be there, hyperresonant on percussion, and cyanosis will be the late manifestation. And investigations, tension pneumothorax is a clinical diagnosis that requires immediate intervention. No need to wait for X-ray or anything. If the signs are present after receiving the patient, trauma patient, if signs of tension pneumothorax are there, immediately we have to go for the needle decompression followed by ICD insertion. So EFAST can be done on bedside for the diagnosis of the tension pneumothorax. And this is the second intercostal space where needle thoracotomy is done in children. And in adults, left fifth intercostal space, mid-axillary line, needle decompression is done. Coming to the open pneumothorax. So open pneumothorax are the most injuries, severe injuries. It can cause tension pneumothorax and everything. And it is a sucking chest wound like injuries will be there. And respiratory distress, patient present with respiratory distress and preferential path of air. And when hole is more than 2/3 of diameter of trachea, it should be covering the management I'll discuss in the later slide. And it should be covered, the open chest injury should be covered by the 3 sides with opening in the 4th side. And chest tube insertion is another management, and definitive surgical closure is required in OT. And the open chest injuries will be done by the wound dressings or open pneumothorax. So it is a 3-way dressing, what we are seeing in this image. So it is clear, it is the dressing will be done to prevent the air from entering in from outside into the open chest injuries. So it causes a flutter wave effect. So here you can see the 3 edges of the wound are covered with the plastic sterile gauze, sterile plastic piece, and that edges should be neatly attached to the skin. And the 4th wall will be open like this. While inspiration, the external air can be prevented from the entering into the chest cavity. And while expiration, whatever the air the patient has in the tension pneumothorax and pneumothorax, that is expired into the open area, wherever the dressing is not kept. Coming to the physical signs in massive pneumothorax. So massive pneumothorax is defined by accumulation of more than 1500 ml of blood in one side of the chest. So coming to the physical signs in tension pneumothorax and massive pneumothorax. In tension pneumothorax, breath sounds are decreased or absent. And in massive pneumothorax, the breath sounds are decreased. On percussion, on tension pneumothorax, hyperresonant will be there. And in massive hemothorax, dull note will be seen, dull percussion sounds. And tracheal position, in tension pneumothorax, it is deviated away due to the hair hunger and everything. So opposite lung is collapsed. So that's why the trachea is deviated in the to the opposite side in tension pneumothorax. And in massive hemothorax, it is tracheal portion midline. And neck veins, coming to the neck veins in tension pneumothorax, it is distended, and massive hemothorax, it is collapsed. And chest movements expanded, immobile, and massive hemothorax, the mobile movements will be there. So here in this X-ray, left side massive hemothorax is seen. So the definitive treatment for this is the ICD insertion to relieve the positive pressure ventilation and everything. So treatment will be the large caliber intravenous lines and infuse crystalloids and begin transfusion of uncross-matched or type-specific blood as soon as possible. A single chest tube, like chest tube of French 28 to 32, is inserted, usually at the 5th intercostal space, just anterior to the mid-axillary line. So these are the borders of the ICD insertion. So it is placed in the 5th intercostal space, mid-axillary line. So anteriorly it is formed by the lateral border of pectoralis major, and posteriorly it is seen by the anterior border of latissimus dorsi, and base is covered by the level of nipple at the 5th intercostal space. Coming to the complications of chest tubes are infection and trauma to the adjacent organs like liver, spleen, diaphragm, aorta, heart can be the complications. And minor complications like subcutaneous emphysema, hematoma, and dyspnea will be seen. And improper placement is also another complication on chest tube ICD placement. So coming to the need, when will place for the need for thoracotomy? The immediate return of 1500 ml or more of blood generally indicates for the need for urgent thoracotomy. So whenever there is patient is not giving us time, patient is very severe distress, then we can proceed for the needle thoracotomy. An initial output of less than 1500 of fluid, but continuing blood loss of 200 ml per hour for 2 to 4 hours may require thoracotomy. So penetrating chest wounds like anterior wounds medial to the nipple line and posterior wounds medial to the scapula, which involve mediastinum, may require thoracotomy due to damage to great vessels, hilar structures, and heart. And coming to the cardiac tamponade is defined by compression of the heart by an accumulation of fluid in the pericardial sac. Most commonly results from penetrating injuries. May also be seen in blunt injuries involving heart, great vessels, or epicardial vessels. And cardiac tamponade results in decreased cardiac output due to decreased inflow to the heart. And EFAST is a rapid and accurate method of imaging the heart and pericardium that can effectively identify cardiac tamponade. And it's a EFAST where we can see RV is slit-like stricture and the pericardial effusion is massive and RV is not at all visible and it is compressing the adjacent organs. It's a massive pericardial effusion, this image. And in this X-ray, there is a cardiomegaly with the pericardial effusion can be seen and it is obstructing the left lung and everything. And in this image is CT image where it is seeing slit-like image. And coming to the survey, differentiate between cardiac tamponade versus tension pneumothorax. So these are the two scenarios where patient will not give time for management and patient will collapse immediately. So we have to take care of the definitive treatment immediately as soon as patient comes and check ABC and EFAST will be done. Depending upon the EFAST findings, we have to proceed very fast. And coming to the clinical signs, and in cardiac tamponade, blood pressure will be low and patients will present in PA also, pulse electrical activity also. And neck veins will be distended and respirations will be normal plus or minus, and cardiac tones are muffled in cardiac tamponade and breath sounds are normal. Coming to the tension pneumothorax, clinical signs, blood pressure is low, neck veins is distended, respiration is tachypnea, cardiac tones are normal, and breath sounds are absent in the collapsed side, tension pneumothorax. Treatment of cardiac tamponade will be when pericardial fluid or tamponade is diagnosed, emergency thoracotomy or sternotomy should be performed by a qualified surgeon as soon as possible, immediately. And administration of intravenous fluids increases venous pressure and improves the cardiac output transiently. While preparations are made for surgery, and if surgical intervention is not possible, therapeutic pericardiocentesis can be done bedside in ED, but does not constitute as a definitive treatment. And this is the site where the pericardial synthesis is done. The apical junction and paraxiphoid area above the needle angled approximately in the 15 degrees above the skin in ultrasound. And coming to the traumatic circulatory arrest. So whenever if the patient, we will be receiving the patient in ED, if the patient has massive thoracic trauma injuries with pulseless electrical activity or unconscious and have no pulse with PEA, as observed in extreme hypovolemia, and this patient's results in ventricular fibrillation and asystole, true cardiac arrest are considered to be in circulatory arrest. So in thoracic trauma, what would be the causes of the thoracic circulatory arrest are severe hypoxia is one of the major cause, tension pneumothorax, profound hypovolemia, cardiac tamponade, cardiac herniation is another cause, and severe myocardial contusions and cardiac event prior to traumatic event. Management, CPR with the algorithm, and ABCD management after achieving ROS. And this is the algorithm in severe thoracic. Whenever the patient has no is in PE, received in ED, so we have to start immediately CPR followed by ABCD. If the patient has no return of spontaneous circulation, continue CPR. And within 2 minutes of ED arrival, if the patient has any open injuries and any tension pneumothorax, if you're suspecting there is no pulse, immediately shift the patient to OT with the cardiac surgeon. And we have to continue with the CPR. If no pulse, everything is not there, then anterolateral or clamshell thoracotomy is done, and vertical pericardiotomy is done. And if cardiac tamponade is there, we have to relieve the pressure by pericardiocentesis. And if you are suspecting cardiac injury, the control of the cardiac tension will be controlled, and repair of the heart wound is seen. Then if there is no ROS, so continue with CPR. If ROS is achieved, then proceed with the ABCD. Then if the patient is in severe hypovolemia, if thorax, open thoracic injuries are there, though, so close the injuries with the three-wave, flutter wave injury management. And in thoracic injuries, pulmonary pedicle or mediastinal injuries are suspecting, hemostasis should be done by clamp or loop, and continue resuscitation. And if there is no raw schedule, so continue CPR. And if you are suspecting abdominal injuries, so clamp on the descending aorta is done, OT. And after clamping also, there is no return of spontaneous circulation and everything. So continue CPR. And if there is no, what we'll say, there is no cardiac activity, then internal carotid massage of the heart will be done. And depending upon the internal electric shock is given. If there is no activity of the heart after 30 minutes or more than 45 minutes of resuscitation, then declare the patient as dead after 30 minutes of resuscitation, and depending upon the scenario of the patient. Coming to the secondary survey in thoracic injuries, the secondary survey in thoracic injuries involves further in-depth physical examination like ECG monitoring, pulse oxy monitoring, and ABG values depending upon the PO2, PCO2, and lactates. What is the HB? If the patient is having open thoracic injuries, he might have tension pneumothorax and hemothorax, massive hemothorax. And depending upon the HB, we need to transfuse the first stabilize the chest area and followed by blood transfusions if required. And chest X-ray in patient without suspecting final column instability. And CT scan is selected in patients whenever we are suspecting aortic or spinal injuries. And coming to the potentially life-threatening injuries are simple pneumothorax, hemothorax, flail chest, pulmonary contusion, and blunt cardiac injury, thoracic aortic disruption, and traumatic diaphragmatic injuries. Blunt esophageal injuries like Beaver syndrome can also cause sudden cardiac arrest due to rupture of the esophagus. It can cause sudden cardiac arrest, and it can lead to subcutaneous emphysema, hypotension, and everything, and patient lands up in cardiac arrest. Coming to simple pneumothorax, the simple pneumothorax results from the air entering from the potential space between the visceral and pleural area. So causes are the blunt trauma to chest, penetrating injury, non-penetrating trauma like lung laceration with air leak is the most common cause of pneumothorax. Coming to the pathophysiology, there will be air in the pleural space that leads to the lung collapse, and that leads to the VQ mismatch, perfusion mismatch will be seen in simple pneumothorax. Coming to the clinical findings of simple pneumothorax, chest inspection for bruising, lacerations, or contusions will be seen, and assess movements of the chest wall on both sides, and hyperresonance on percussion, and decreased breath sounds on affected side is seen. And chest X-ray is the diagnosis, is simply a diagnosis in the pneumothorax. Management in simple pneumothorax is chest tube insertion. Patients with pneumothorax should not undergo general anesthesia. It does anything like everything will be done under local anesthesia and receive, or they may not receive positive pressure ventilation without chest tube insertion. So whenever we will be suspecting or tension pneumothorax and everything, first we need to insert the needle thoracotomy or ICD insertion. Then only we need to intubate the patient. If the patient is in gasping state or anything, first do a needle thoracotomy or ICD insertion as early as possible, then intubate the patient. Then afterwards followed by chest decompression to be done before a transplant of patient due to expansion of pneumothorax at high altitude. So coming to the next topic, hemothorax. Hemothorax is the accumulation of blood less than 1500 of ml in pleural cavity. The primary cause of hemothorax is laceration of the lung, great vessels, and an intracostal vessel or an internal mammary artery from penetrating or blunt trauma. So thoracic spine injuries may also be associated with hemothorax. The clinical features of hemothorax would be expose the clinical examinations of hemothorax, expose the chest and cervical areas, observe the movement of the chest wall. We need to observe for the movement of the chest wall. So we need to look for any penetrating chest wall injuries, including posterior thorax also. So access and compare breath sounds on both sides of chest. So there will be a dullness on percussion of the affected side on hemothorax. So obtain chest X-ray with supine position. Management in hemothorax. If an acute hemothorax is there that is large enough to present on X-ray, it may be treated with a 28 to 38 French chest tube. No need to use for the 36 or 38 size French tube. We'll go for the 28 or 32 French ICD. Though the chest tube evacuates blood, then afterwards it reduces the risk of clotted hemothorax and allows for the continuous monitoring of blood loss. And coming to the flail chest and pulmonary contusions. And flail chest occurs when a segment of the chest wall does not have any bony continuity with the rest of the thoracic cage. And causes usually results from trauma associated with multiple rib fractures, that is two or more adjacent ribs fractured in one or two more or more places. It can also occur when there is a costochondral separation of the single rib from the thorax. Diagnosis can be done by abnormal respiratory movements and palpitations of crepitus from rib or cartilage fractures. X-ray would be the definite finding for flail chest and pulmonary contusion. And pulmonary contusion it is a bruise of the lung. So most commonly caused by the rib fractures or flail chest in adults. Children have more complaint chest walls than adults and may suffer contusions and other internal chest injuries without overlying rib fractures. So here in this picture, while inspiration, the multiple refractures are accommodating the adjusting to the costochondral angles and everything. While expiration, the rib movements are away from the fractured area, and it results in the positive ventilation, pressure ventilation in the chest, and it results into the accumulation of blood and everything. The costochondral disruption will be seen in the flail chest. So in this, it can be managed by giving painkillers, opioids, and everything. And if the patient is having pneumo or chemo, depending upon the findings, we need to plan for the ICD insertion as early as possible. And in this X-ray also, we can see multiple fractures seen on the right side, and there is a very minimal pneumo also in this X-ray. And management, management of flail chest and pulmonary contusions. Administration of oxygen is first thing, and adequate ventilation and cautious fluid resuscitation will be done. And adequate analgesia or narcotics or local nerve blocks and epidural analgesia is also useful in pain management in flail chest. Patients with significant hypoxia and also comorbid conditions such as COPD, renal failure may require intubation and ventilation within first hour of injury in flail chest. Coming to the blunt cardiac injuries, and is the most commonly seen in the RTAs and fall from height, blunt cardiac injuries. And the injuries may be myocardial contusions, cardiac chamber rupture, presence with cardiac tamponade identified in primary survey, coronary artery dissection, or thrombosis and valvular disruption. And symptoms in cardiac blunt trauma could be chest discomfort and pain, and breathing difficulties will be seen. And clinical signs are dysarrhythmia, hypotension, there will be raised JVP, suggestion of RV dysfunction, and secondary to the contusion. EFAST can be helpful in diagnosis, and there will be regional wall motion abnormality on echocardiogram. And ECG suggestive of ST changes, PVCs, sinus tachycardia, atrial fibrillation, and pulmonary branch also can be seen in some patients. Coming to the traumatic aortic disruptions in thoracic trauma. So it is also a major mortality in chest trauma patients seen. And it is one of the most very rarely seen, and it is one of the high mortality rate in thoracic trauma patients. So traumatic aortic rupture is a common cause of sudden death after a vehicle collision or fall from a height. So occurs commonly at the ligamentum arteriosum. And here we can see the arch of aorta disruption is due to trauma. And the radiographic features of blunt aortic injuries are widened mediastinum will be seen, infiltration of the aortic knock, and deviation of the trachea to the right. Depression of the left mainstem bronchus is seen, and elevation of the right mainstem bronchus, and obliteration of the space between the pulmonary artery and the aorta, that is obscuration of the aortopulmonary window, and deviation of the esophagus to the right, and widened paratracheal stripe and widened paraspinal interfaces, and presence of a pleural or apical cap can be seen, and hemothorax, and fractures of the first or secondary bar scapula would be seen. And CT chest with contrast is an accurate screening method for suspected blunt aortic injuries. But transesophageal echo is a less invasive diagnostic tool. So treatment in the aortic injuries are mainly analgesia, short-acting beta blockers to control heart rate, blood pressure control, and we have to maintain the map of between 60 to 70 mmHg. And surgical opinion, immediately intervention is required. CTVS intervention is required if a definitive finding of aortic injury is there. And coming to the traumatic diaphragmatic injuries, and blunt trauma in diaphragmatic injuries produces large radial tears that leads to the herniation of the abdominal structures into the thoracic cavity. So penetrating trauma produces small perforations that can remain asymptomatic for years. In diaphragmatic injury, diagnosis can be done by X-rays by bedside, CT scan, and upper GI contrast study, and peritoneal lavage fluid in deep peritoneal lavage is seen. And minimally invasive endoscopy procedures like laparoscopy or thoracoscopy can be done for the repair of the organs. And here in this picture, we can see the diaphragmatic injury. The left side, the diaphragm has been ruptured, and the gastric contents, intestinal contents have been entered into the left side lung cavity. And it is also seen in this X-ray also, the diaphragm is ruptured and it is elevated, and the intestinal, like stomach and intestine organs have been entered into the left side of the chest cavity. These both X-rays, as you can see. And diaphragmatic injuries are frequently missed initially when the chest film is basically misinterpreted as showing as elevated diaphragm and acute gastric dilation and loculated hemothorax or subpulmonary hematoma. Treatment is by direct repair. There is no definitive treatment for these diaphragmatic injuries or the surgical intervention. You mentioned 100% is required. And care must be taken when placing a chest tube in patients with suspected diaphragmatic injuries to not injure the organs which are seen. And coming to the blunt esophageal rupture, and esophageal trauma most commonly results from penetrating injuries like stab injuries and everything. And it can be seen, very rarely seen in thoracic injuries, and rarely, but esophageal trauma caused by the forceful expulsion of gastric contents, whenever the patient is driving in a car, whenever the whiplash injuries, and in not commonly seen, but it is very rarely seen. And due to that, the expulsion of the gastric contents into the esophagus from the severe blow to the upper abdomen. And forceful ejection produces a linear tear in the lower esophagus, allowing leakage into the mediastinum, resulting in mediastinitis and empyema. Coming to the symptoms of blunt esophageal ruptures are identical to that of post-emetic esophageal procedures. So it is also seen in most commonly seen after doing upper GI endoscopy and everything. And the symptoms will be the pain or shock out of the proportion to the apparent injury. Particulate matter may drain from the chest tube. Investigations or contrast studies, esophagoscopy. Treatment is wide range of pleural space and mediastinum with the direct repair of the injury. Bevier syndrome. Other manifestations of chest injuries are subcutaneous emphysema. Subcutaneous emphysema can result from airway injury, lung injury, or air blast injuries also. So must recognize the underlying injury and treat it. If positive pressure ventilation is required, consider performing immediately tube thoracostomy on the side of the subcutaneous emphysema in case a tension pneumothorax develops. No. Crush injuries to the chest. In this type of injuries, plethora with petechia, fossa facial, and arm secondary to the acute and temporary compression of the superior vena cava. Even cerebral edema may be present if crushing injuries to the chest is seen. And coming to the rib, sternum, and scapular fractures, the ribs are the most commonly injured component of the thoracic cage. And pain or motion typically results in splinting of the thorax, which repairs ventilation, oxygenation, and causes atelectasis, pneumonia with pre-existing lung diseases. The scapula, humerus, and clavicle, along with their muscular attachment, provide a barrier to the injuries to the upper ribs, like 1, 2, 3. And fractures of the scapula, first or second rib, or the sternum suggest a magnitude of injury that places the head, neck, spinal cord, lungs, and great vessels at risk for serious associated injuries. Missing. Scapular fractures generally results from a direct blow. And operative repair of the sternal and scapular fractures occasionally is indicated. So rarely, posterior sternoclavicular dislocation results in mediasternal displacement of the clavicular heads with accompanying superior vena cava obstruction, where immediate reduction is required. The middle ribs, like 4 to 7, sustain most of the effects of the blunt trauma. And anterior posterior compression of the thoracic cage will blow the ribs outwards and cause midshaft fractures. Fractures of the lower limb, that is 10 to 12, should increase suspicion of hepatosplenic injury. And localized pain, tenderness on palpation, and crepitations are present in patients with these injuries. Management in these patients will be relief of pain is important to enable adequate ventilation, early and aggressive pain control, including the use of systemic narcosis and topical, local, or regional anesthesia that improves outcome in patients with rib, sternal, or scapular fractures. Coming to the summary, life-ending thoracic injuries are common. So high mortality are seen in thoracic trauma patients whenever we receive the patient in ED after coming to ED. During process of stabilization, only most of the patients will collapse. And survival depends on proper and immediate diagnosis and appropriate management. And ED thoracotomy can save lives, but expected survivors in less than 10%. Don't forget ABCD you need to follow in trauma and damage control principles. Thank you. Hello, Azim sir.
Hello. Sir, nice presentation, sir.
Thank you, sir.
Uh, Thank you, sir. Thanks a lot.